Hello, my name is Thomas Bogar. I am a nationally registered paramedic and board-certified flight paramedic. Today, we're going to be talking about pediatrics and pediatric patients that we may see in the field here at Midwest Medical. So when it comes to pediatric patients, it is important to remember that children are not just small adults. They vary vastly in anatomy and physiology from other of their peers of the same age and cannot be treated just as small, condensed adults. The way their anatomy works and the growth and changes that happen during the body during that process makes every pediatric a unique and special case. Children are often unable to effectively communicate in emergency situations. That's why you need to always be assessing your patient. We'll go over a couple of strategies that you can use from just coming in from the door to assessing during transport to monitor pediatric patients. As always, do not rely on the monitors, from pulse oximeters to blood pressure cuffs for assessing your patient. Be sure you understand and know what you're looking for and what to watch out for in all of these scenarios. And that point at the end there is very important. Children do decompensate fast, so be ready for any change that could happen. 1 minute to the next could be two totally different scenarios. When it comes to the cardiovascular system of pediatric patients, there's a couple different things here. Obviously there's a list of congenital heart defects that children can have. You might see in, our infants, neonates, even to, very young toddlers might still have some of these defects present, and they may last all the way through their life. One here that's kind of highlighted is the patent ductus arteriosus, and you can see that in the picture here. Blood coming through the left ventricle comes up the aorta and then into the pulmonary arteries. That usually closes within minutes to a few days after birth. However, the anatomy is basically the same as adults. You still got your right ventricle, your right atrium, left ventricle, aorta, pulmonary arteries. You've got arteries and veins and capillaries all throughout the body. It's just, it usually contains a lot less blood as well. So that's another thing to be watching out for. A child loses blood and they lose a significant amount, it'd be a much greater issue than if an adult lost a similar amount in comparison. Another thing it says here down here at the bottom, pulse rate and blood pressure does vary between children. And this is just another good chart, kind of outlining, or not outlining, just kind of showing you the comparisons of the different blood pressures that children can have as they grow. This is in years, so there's no years up here, should be for the column, but seeing all the way from 3 all the way down to 18, you can see how systolic blood pressure increases and diastolic blood pressure increases for both boys and girls, and it's pretty comparable between the two. Just slight differences, like here at 6, 105 to 104. Diastolic is still about the same, but like I said, it should be nearly identical for both boys and girls in terms of increasing from years of 3 to 18. When it comes to the respiratory system here of our pediatric patients, in comparison to adult airways, the lower airways of children are smaller, more prone to obstruction and collapse. A big one here is that children have a larger tongue in relation to the size of their mouth. So the tongue itself may become an obstruction and may occlude the airway easier than it would in a normal adult patient. Down here I found it was a pretty good image just showing you the comparison of adult upper airways versus the child's upper airways. I was saying the tongue is larger, the pharynx is smaller, the epiglottis is larger and floppier, the larynx is more anterior and superior. It's narrowest there at the cricoid cartilage, and the trachea narrow and less ridges than what you'd find in a full adult patient. The musculoskeletal system also different in pediatric patients as compared to our full-grown adult patients. Pediatric bones are more porous. They tend to buckle rather than fracture. They have fewer calcified bones. The epiphyseal, metaphyseal growth plate injuries account for about 10 to 15% of all fractures in children. When that growth plate's fractured, that can lead to, further issues with that long bone growing. So, it's always something to watch out for. A lot of times kids might break their arm and it'd be a green stick fracture like what you see here in the slide. I found kind of an image of the green stick fracture. It breaks, but it's not a full shearing, or it just breaks and comes back just due to that flexibility that their bones have. So at the, in reference to the top one, they buckle more than they do fracture. Here's another little addition on the, just in terms of the musculoskeletal system of pediatric patients. The pediatric spine has incomplete ossification, epiphyseal growth plates, and hypermobility. So children's spines are flexible, so they tend to have avulsions rather than fractures. So I went on and I kind of was looking for a good photo of avulsions just because I found it interesting. So it's kind of like a separating rather than a breaking. So that's what you can kind of see. That's what these arrows are kind of pointing to here, is that separating rather than just like straight up breaking the bone itself. The gastrointestinal system of children, and pediatric patients in general, you generally have an increased risk of aspiration. And that kind of goes along with, that size of the airway when we were looking back a couple slides. And the, more pliable epiglottis, all that kind of just leads to your increased risk of aspiration. They have a smaller stomach capacity, so the chances of the stomach being full are higher than you would see in adults. Children like to have lots of snacks during the day, but they can't eat like a huge meal just because their stomachs are so small. Their abdominal muscles are weaker and thinner, which increase risk of injury to their internal organs. So you see like an abdominal injury where, some sort of blunt trauma to the abdomen, you'd want to be thinking, okay, well, this child may be at an increased risk of an injury to the organs. And so what could be going on here? Looking for your signs and symptoms. The liver and other organs are not fully developed, leading to fewer glucose stores. That's another big one too. So in children who do have diabetes, or not even diabetes, but just maybe going into like a state like shock, something like that, they have the fewer glucose stores, and their organs aren't as developed, so they may not be able to handle these kind of stressful situations as well as a full-grown adult. So it's always something to be on the lookout for. This is just a slide here showing kind of a generalized view of the GI tract. Starting with the mouth, the esophagus, going to the stomach. Then you have the biles produced in the liver, stored in the gallbladder. Let's see, we got the small intestine, goes all the way through here, and then ends up in the large intestine and goes all the way out. Just one big tract all the way through. Thermoregulation of pediatric patients. They'd be more susceptible to hypothermia. So when this video is released here, it's January, almost February. It's a very cold time of the year. And children may not be properly dressed, running around outside. Now think of it and then, slip into hypothermia quickly. Their skin is thinner. They have little to no subcutaneous fat. A good fat layer like that helps insulate the body. Protect them from cold. Their heat will dissipate quickly, and they will react poorly in extremes of temperature. When I say extremes of temperature, I mean extreme heat or extreme cold. So temperature gets way up there, they get really hot, you see them get flushed. That's when you're looking for your signs and symptoms: heat exhaustion, heat stroke. Get really cold, look for hypothermia. And the other thing is, surface area to volume ratio. It's 4 times that of an adult, and the heat production only takes 1.5 times as high. So just make sure you keep an eye on kids when temperatures get to the more extreme sides, either extremely cold or extremely hot. Another thing to watch out for, it gets really cold and they get wet. Anytime someone gets wet and it's super cold, so you're always looking for hypothermia. Here we just have a good little image of, just kind of thermal regulation, very, very basically. You activate, person gets cold, their heating mechanisms are activated, starts to heat up their body temperature increases, and then let's say it's too hot outside, and then they get hot, cooling mechanism activates, and it decreases body temperature. That's essentially just the cycle of how your body tries to maintain its body heat. So metabolism in pediatric patients is higher. They have a higher metabolic rate than adults do. An infant's consumption of oxygen is twice that of an adult. Hypercapnia and hypoxemia is also accelerated in children. I also added this is the time to hemoglobin desaturation. I thought thing is pretty useful. I just kind of added in with the consumption of oxygen. You've got this is just how long it takes for the hemoglobin to desaturate. So someone to desaturate once they're no longer totally breathing on their own. So if you hear it, if it's all the way up here, 99, almost 100. First one to come down in desaturation, this is in time in minutes, is an obese adult. Next is a child. And then after that you have a moderately ill, normal sized adult. And then you have a normal adult. So as you see, children here, this whole curve drops off really fast. So it's something you always want to be watching out for. Another thing is the pediatric assessment triangle. So this is your general impression. So this is something that you can do, when you walk in the door, doing a quick assessment of your patient. Once you walk up to them, it's something that's kind of always going on in the back of your head. It's generally shown as a triangle here. So you've got appearance, work of breathing, and circulation of skin. Down here, this is kind of outlining what each of them might be indicating. So if everything is normal and good, then the child appears stable. If they're having increased work of breathing, they're breathing rapidly, trying to take really deep breaths and really fast or short, really fast breaths, that work of breathing, you're looking at maybe some respiratory distress. If their work of breathing's increased and their appearance is, they're becoming a little more pale, perhaps, and they're not looking good. You just walk in the door and you see, okay, pale, diaphoretic, increased work of breathing. You're thinking, okay, this might be respiratory failure. If their appearance is off and they have poor circulation to their skin, you might be looking at shock. Or if it's just poor circulation to the skin and without the appearance, you still might be looking at shock. Remember, kids decompensate really fast, so you want to stay on top of it and be absolutely ready for it if it does happen. If it's just that their appearance looks bad and their circulation of skin is good, their work of breathing is good, you might be looking, okay, maybe this is a CNS or a metabolic disorder or some sort of illness that would be affecting these and would change their appearance. If their appearance, work of breathing, and circulation of skin are all bad, then you might be looking at the cardiopulmonary failure here. So that'd be the full triangle. Alright, similar to the pediatric assessment triangle, there's the Tickles mnemonic. It stands for tone, interactiveness, consolability, look or gaze, speech or cry. So the tone, is the child moving or resisting examination vigorously? Are they really fighting you? Do they have good muscle tone? Are they just limp, listless, and flaccid? Remember, we want children to kind of fight and stay away from us. If they're limp and they're just flaccid, it's a bad sign. Interactiveness, how alert is the child? How readily does the person, object, or sound distract the child or draw their attention? You talking to them, are they looking at you? Or are you just talking and they're totally spaced out? Do they reach for things? Are they trying to grab stuff that might, maybe you have a stethoscope and they're trying to grab that? Or they're reaching for mom or dad? Can they be consoled or comforted? Can the mom or dad or caregiver soothe the child at all? Is there crying or agitating? Not relieved, but just kind of reassuring. Maybe just kind of stroking their head. Look or gaze. Does the child fix his or her gaze on it? Or is there nobody home, glassy eyed stare? They're just staring off into nothing. Speech or cry, is the child's cry strong and spontaneous, or is it weak and high-pitched? Here you're just looking for, anything you could try and tell from their voice. Does it sound like they have some sort of upper respiratory infection? Is it lower respiratory infection? Does it sound like there might be like a stridor that you hear? Are they crying? That's another good thing to look out for. Alright, with pediatrics, just like with adults, you always start with the airway, breathing, circulation once you get to your primary assessment. Airway, breathing, circulation. With the pediatric airway, at this time, you get to that point of the ABCs, you're starting in the airway. At this time, you want to consider C-spine immobilization. It's always one of the first things we want to look to when we start in on our assessments of patients. When you open the airway, the sniffing position, with pediatric patients, due to, the proportion of their head to their body, you'd want to place a towel underneath the shoulders, so that way it doesn't occlude the airway when you place them in the sniffing position. You're looking for, if there's, if you're hearing stridor, something like that, you'd be looking for your airway obstructions, things like secretions, objects, toys would be a common thing, other things that maybe a small child might accidentally swallow while they had in their mouth. Looking for swelling or even having the tongue as an obstruction, that's another thing you'd also want to look out for. With breathing, you're looking for the work of breathing in a pediatric patient. Now that's just kind of in general with all patients. So here we're looking for what can we hear when the patient's breathing. Can you hear stridor, snoring? Does it sound restricted? Are they bobbing their head? The accessory muscle use, that's always a big one with pediatrics. Tripod positioning, nasal flaring, wheezing, grunting. Are they anxious, irritable? Can you console them? All these are big things to be looking for with pediatric patients. When it comes to pediatric patients, what we're looking for, a lot of times we base our clinical evaluations off of, what we can measure. So like measuring respirations, and that SpO2, is another wonderful measure that we use to determine how well a patient is breathing. In pediatrics, the SpO2 should be greater than 92. Ideally, you want it better than 94, but greater than 92 is just fine. You may need to use a pediatric pulse oximeter. You may need to place the probe on the foot too. The pediatric that's small enough, sometimes that's the best place that you can get it. The end tidal CO2 ranges, still 35 to 45, even in a pediatric patient. Circulation of a pediatric patient, so that you're seeing your ABCs. The skin vitals are the key here. Looking at what do I see when I look at this patient. A capillary refill, less than 3 seconds is the normal. When it comes to checking pulses, you're looking for strength, you're looking for the rate, and then especially with pediatric patients, we're looking at the central pulses versus the periphery. Depending on the age in that, if you have an infant versus a 16-year-old, obviously you're going to have a large difference in what you're looking for. When we're talking about central pulses, we're talking about the brachial, we're talking about the femoral pulse. Periphery, you're looking radial, you're looking pedal. Here it's just making sure you assess the circulation. Here I've added kind of a nice chart that I think kind of outlines some of the stages of childhood. So here we got, toddler, preschooler, middle school, and pre-adolescence. These, as you become more disconnected from being like a child, at least personally, I feel that sometimes I may forget what the specific age ranges for like toddlers and preschoolers, and what middle childhood looks like. So this is a wonderful chart, just I think, for looking at that and kind of a good use for what to be on the lookout for and what each stage may look like. And to kind of go off of that last chart that I had there, I added in some normal pediatric vital signs. I found this great table. So as a stage, infant, toddler, preschool age, school age, and the adolescent, giving you your respiratory rate. And so as you can see, it starts to decrease from an infant down to, or kind of up as they age, the respiratory rate decreases as the age increases. Kind of inverse there. Pulse rate, here again, the pulse will decrease as the age increases, from infant to an adult. And then the blood pressure will increase with age. So that one does increase proportionally. The FLAC scale here, standing for face, legs, activity, cry, and consolability. This is a scoring method for determining how much pain a child who is unable to communicate with you, how much pain they're having. You have like infants or very young toddlers who may not be able to tell you how much it hurts. This is a scoring measure you can use to determine how much pain that child is in. And with this particular scoring chart, it's the higher the score, the more pain the child is in. Here we have the classic Glasgow Coma Scale, or GCS. This is usually one we're usually pretty familiar with at this point. Looking for eye opening, the best verbal response, and best motor response. And what it means by best verbal response is, you're taking what the best response that they can give would be. So if they had a one-off time of maybe seeming a little confused or a little off, but the best response that they had is they knew what was going on, then it would be a 5. They're oriented to time, place, and person. It's the best response that you get from the patient. Yeah, but don't take it as at the beginning of the trip they had they were oriented to time, place, and person, and then by the end of the transport they were very confused, and they certainly would not be oriented to time, person, and place. In a situation like that, then that would be a decrease, and that wouldn't be a best verbal response scenario. You'd be taking the best verbal response at that time. I think that's probably a better clarification of that. Furthering our look at neurologic assessments here, looking at the muscle tone. So normally children have the flexed elbows and knees. They're not totally relaxed and flaccid. If they are flaccid, that's an abnormal finding, and you'd be considering a possible neurologic injury at this point. Here I added kind of like a figure that I found was pretty good for a handful of the infant reflexes. As you can see here, rooting, so it'd be stroking the infant's cheek and they turn in the direction of that. Looking for feeding, gripping, so if you place something in the infant's hand, the infant's going to grasp and hold on pretty well. Toe curling, so if you just run your finger along the inner or the outer side of the infant's foot, they're going to curl their toes if it's on the inside, and if it's outside, then their toes are going to spread out. The Morrow reflex, so if you make a sudden noise or movement, then they're going to throw their head back and arms and legs out. And the Gallant reflex, so if you stroke the infant's lower back next to the spinal cord, then they're going to curve towards that side that was stroked and look like a fencer when doing so, as you can see in that little image up there. Here's a nice little image of what croup would look like, and what causes the development of that stridor and the seal barking cough. So he's got a little diagram of the larynx there, and you can see that the swelling around that's what you're gonna hear a lot of the stridor from, and the cough, that forcefulness of the air flowing through that, the voice box, is what's going to give you that barking cough. Epiglottitis is a bacterial infection from Haemophilus influenzae. It's common, ages 3 to 8 years. Here it's associated with fever, stridor. This is a big one to look out for. Epiglottitis is not an infection that you'd want to mess around with. The risk here is complete airway obstruction. So these may be kids that be sitting forward and they may be drooling because it hurts so bad just to swallow that they'll just go ahead and start drooling. This is something you see in adults too. Much rarer in adults, but you'd see in a severe case of epiglottitis that the adult may be drooling too, just because of that pain that comes from the swelling of the epiglottis. Administering blow by oxygen with these pediatric patients, doing everything you can to not have to agitate the area. With these patients, if you are going to do something if it comes to the point where you think you're going to have to intubate, like, do it quick and get it on the first one, because agitating that epiglottis and causing further inflammation may, like it says there, risk your complete airway obstruction. Here I've added the epiglottis and what the epiglottis may look like with epiglottitis. Here you got normal epiglottis right here, and you've got you can see the vocal cords in there. But when you're looking at epiglottitis, it's really swollen and red. You can see how that starts to cover up everything, and how that could easily occlude the airway. So that's why we're really concerned about epiglottitis. Next is bronchiolitis. This is a viral infection of the lower airway. This leads to inflammation of the bronchial tissues. Toxins and other byproducts accumulate in those lower airways. This is more of a slow onset infection. It's usually associated with some tachycardia, tachypnea, a little bit of fever, increased mucus production. You may hear some wheezing, coughing, and they might feel that sensation of some chest tightness there. So with bronchiolitis, what we're looking to do is to reverse bronchospasm. And doing so, we're also trying to reduce the airway inflammation, so that way they don't get so constricted, and it allows us to correct hypoxia. We get better perfusion to the lungs, better perfusion to the body. The old adage, you want the air to go in and out. You want it to go in and out the best you can. So here we can consider using Atrovent or Oduneb. These uses are kind of controversial. So generally, if you're going to use a beta agonist, you do that before you use the bronchodilators like albuterol. So that's why it says consider Atrovent or Oduneb. And Atrovent's the other name for that medication would be ipratropium bromide. Here's a little bit of a diagram of bronchiolitis. So here, you got your inflamed bronchial wall, and then with that mucus production in the middle, you can see how there's just no air is going to get really exchanged all the way down in the alveoli there. So it's important to try to reduce that inflammation the best we can. A very common one would be asthma. Now, in comparison to croup, epiglottitis, bronchiolitis, asthma is a chronic inflammatory disorder of the lower airways. So this can be triggered by infections or allergens. It can be triggered by exercise, emotional. There's all sorts of different things that would trigger someone's asthma. And with asthma, it could result in bronchospasm or pulmonary edema. So to treat asthma, usually you'd use some oxygen, bronchodilators. Lots of asthma patients, most asthma patients will probably know that they have asthma. They'll probably have their inhaler with them. So just knowing, they've probably had to manage this, all their life up until now. Pediatric patients, they might not be managing it to the fullest extent. But just knowing that, like I said earlier, with asthma too, pediatric patients can go down fast. So staying on top of it is certainly key into treating
asthma. Here, considering corticosteroids in conjunction with other therapies. So, like, you're looking for DUNEBs definitely in this point. Here we have a little diagram again, just kind of showing us what normal bronchioles would look like. You can see lots of space for air to go in and out. Asthma, all that inflammation is just going to constrict it down real bad. So that's what we're trying to get from just constricted to dilated to here. Pneumonia is, I suppose it's more of a general term. So this is like a disease in the lung itself. So you can get pneumonia from something like COVID, or you get pneumonia from a different kind of viral infection or a different kind of bacterial infection. The younger the age, the harder the disease is on a child. You want to watch for the work of breathing, how hydrated the patient is. Generally with pneumonias, they've probably been sick for a while. It's difficult to get fluids in. You're feeling sick, especially for kids. So just make sure you want to take a look at their skin turgor. Always assessing your ABCs. Antibiotics may be necessary to treat pneumonias. And if worse comes to worse, it may require intubation if the child does decompensate. Here's just a little figure today. It's a little blurry, but just some common pathogens that cause pneumonia that I found. So it's fungi, different viruses, we've got different bacteria on here. All these things could lead to all different types of lung-associated pneumonias. Alright, and that's the end of the slideshow. I'd like to thank you guys all for watching, and hopefully you stick around for the next one.